Hello, my name is David Kooby. I'm a surgical oncologist with Emory University and the Winship Cancer Institute in Atlanta, Georgia. I focus on gastrointestinal malignancies and primarily on foregut malignancies, which would include malignant tumors of the benign and malignant tumors of the liver, stomach, pancreas, and intestines. So patients undergoing surgery for small bowel neuroendocrine tumors may be faced with an array of symptoms after surgery that can revolve around the actual amount of small bowel removed or the actual tumor type that is being treated. One of the things that's valuable to the surgeon and the patient about the small bowel is that the typical person who's not had prior surgery has about 6 meters of small intestine. That's almost equivalent to 6 yards. And therefore, because these tumors tend to be on the smaller side, we can remove a good amount of small intestine really with no ill effect for the typical patient. So what it really depends on the scenario that the patient's facing. So when we find these tumors, oftentimes we don't even see the original small tumor that they have in the intestine, but we see enlarged lymph nodes, which will be in the base of the blood supply to the small intestines. And this is where it gets a little bit tricky. The way I describe it to patients is that if we're going to do an operation to remove the small intestine, I don't want them to think of it as a garden hose, but I'd rather them think of it more like a pizza, where the crust is the small bowel and the actual cheese part of the pizza is the mesentery. That's the part that has the blood supply coming in and out of the intestines. Lymph nodes, just like a breast tumor can go to lymph nodes in the armpit, well, lymph nodes can travel from a small bowel neuroendocrine tumor into the blood supply of the small intestine, again, the cheesy area of the pizza. So when you go ahead to do surgery and remove these tumors, you don't just remove the crust, but you also have to remove a section of the cheese area, almost like a pizza slice. And that's where the lymph nodes are, and that sometimes will dictate how much of the small bowel you have to remove. In order to clear the lymph nodes, sometimes you have to remove quite a bit of the cheese area, so you have to take more of the small intestine. Otherwise, it will become devascularized and not survive. So in a person, again, coming back to 6 meters of small intestines, we can sometimes be faced with taking out about half or 300 centimeters of small intestine. And that patient initially might have some symptoms of what we call short gut syndrome. And what that means is that food will tend to run right through because it's not being absorbed as efficiently. That's where most of the absorption of the nutrients happens, in the small intestines. And patients can struggle from that perspective. Typically, if we remove over 5 meters of small intestine, then those patients may have permanent ill effect, whereas patients who have retained more of their small bowel will ultimately recover with some dietary modification. So going into surgery, the surgeon can often have that conversation with the patient to tell them what they expect the side effects will be. But ultimately in the operating room is where you may find some additional issues or findings that make you have to remove more small intestine in order to get the tumor completely out. Aside from those symptoms of short gut syndrome, some patients will also develop adhesive disease after having a small bowel resection, where they can develop partial bowel obstructions or complete bowel obstructions. It really depends on what else is done at the operation as well. Another factor, some people will lose their gallbladder with surgery on the neuroendocrine tumors or carcinoid tumors because They may be faced with going on long-acting somatostatin analogs to try to control metastatic disease. And those patients are prone to develop gallstones. And so if they have a gallbladder, sometimes it's recommended that the gallbladder comes out at the time of surgery. And those patients may struggle symptom-wise with eating fatty foods, which can cause some crampy abdominal pain. And then finally, I think it's important to comment on carcinoid syndrome, which we'll get into with some of the other specific topics that we discussed today. But if a patient has metastatic disease to organs such as the liver, it is possible that the tumors will elaborate or produce a chemical such as serotonin, which can cause carcinoid syndrome. And those patients also will have crampy abdominal pain, watery diarrhea, and symptoms that can really make them feel fairly miserable, which can be managed medically with somatostatin analogs as well. And in terms of resolution of the symptom, it really just depends on which symptom we're discussing, whether it is a simple small bowel adhesion from scar tissue, whether it's short gut, or whether it's carcinoid syndrome, because the carcinoid syndrome, if once it's discovered, it can be managed medically, and oftentimes they'll have fairly quick resolution, whereas short gut syndrome symptoms may last much longer and require much more multidisciplinary medical attention.